Hi, all the doctors out there. It's good to see all of you online. I'm very honored to speak today on this topic, as it is a new topic for me as well. I just want to say hi to all the doctors out there from Indonesia, Malaysia, Singapore, Taiwan, Thailand, Vietnam, Australia, and Hong Kong that signed up for the webinar. It is a short 1 hour webinar. It's a whole new topic besides Invisalign for me. I want to share some of the facts and knowledges behind on how I try to integrate this device into my clinic workflow. So the content for today is categorized as the following. We will review a little bit on the background and science of the biology of tooth movement. And then we're going to take a look on some cases that I did with the vibration technology and how this method or how this implementing the device benefit and value my practice for the past few years. I'm still new to this technology, but I had gained some experiences, and it's really awesome to be able to share it all here today. And I hope all of you will enjoy the evening with me. As for the situation now, we're not able to see each other, but with this new platform of sharing and learning, I think it's really great. It has changed a lot of our daily activities and habits. And it also has changed a lot on how we do things every day. So we'll go on with the first section. So first of all, we're going to review a little bit about the background and the science of tooth movement. So there are three theories of tooth movement. One, there is the pressure tension theory. Second, there is the blood flow theory. And third, there's the piezoelectric theory. So before we talk about the system, about the device, about the cyclic forces that will help with any tooth movement, I think it's very critical and very important to get back to the basics. So what is the pressure tension? In 1932, Schwartz proposed the pressure tension theory on the biology of tooth movement. So when you give a tooth a force, a push force, the teeth moves, right? So what makes the teeth move? According to the pressure tension theory, there is the tension and the pressure side. When a tooth is subjected to a force, it results in areas of tension and pressure. The alveolar bone is resorbed whenever the root compresses the PDL. This is the pressure side, okay? On the pressure side, you will find bone resorption and osteoclast activity. And on the tension side, where there is the force, new bone is deposited when there is a stretching force on the bone, and that is the tension side, with bone deposition and osteoblast around this area. So it is a series of bone resorption and bone deposition that causes a tooth to move according to the pressure tension theory. And the second theory is the blood flow theory, or the fluid dynamic theory, proposed by Bien in 1966. And according to his theory, a tooth movement occurs as a result of changes in fluid dynamics in the PDL. So piezoelectricity is a phenomenon in many crystalline materials. So when a force is subjected to a tooth, okay, then you'll find PDL compression. As a result, the blood vessel will have some occlusion, and then you will get a ballooning of the blood vessels and a decrease in the oxygen level that causes bone resorption, and then a tooth movement follows after the bone resorption. This is the blood flow theory. So it is talking about the different fluid dynamics in the PDL system. And according to this theory, when a bone is subjected to a force, okay, the deformation of the crystal structure produces a flow of electric current that induces tooth movement. So when the force is applied to a tooth, the bone bends, as you can see here in the slide, okay? The areas of concavity are associated with negative charge, okay? And on the top, okay, and causes bone deposition. Areas of convexity on the bottom, okay, are associated with positive charge and cause bone resorption. So it has similar idea as the pressure and tension theory, okay? So with all these electric signals, it will modify the cellular activity in the bone structure and increase the bone remodeling rate that causes the tooth movement that you will see after orthodontic force is applied to a tooth. So you see bone deposition on the top and bone resorption on the bottom. Okay, as a result, tooth movement occurs after this process. And some possible sources of electric current that can induce the piezoelectric signals or the blood flow theory are collagen and hydroxyapatite. All of these two materials are found in our bone and our alveolar bone as well. So that's why Bien in 1966 proposed the theory of blood flow theory for the biology of tooth movement. So what are the phases of tooth movement? Okay, after we talk about the tooth theories, there are we have to go over with the phases of tooth movement. Usually with tooth move usually when we're talking about tooth moving in a socket after an orthodontic force, there usually are three phases. One is the initial phase, then it enters the lag phase in which nothing moves, and then the post-lag phase after the hyalinization, and then the teeth moves. So under the initial phase, usually with the application of force on the tooth, you will see a displacement of tooth in the socket suddenly after a few seconds. And then after the initial stage, it enters into a phase called the lag phase. There is little or no tooth movement during this phase. And during this phase, you see activation of cellular components. If the force is high or strong, usually the lag phase will become long and durated. So usually sometimes, it takes time. If we are using a lot of high forces on our patient, it will use up a lot of treatment time. However, what is optimal as an orthodontic force is low constant force. With low constant force, we're going to get a short lag phase, which will save us a lot of treatment time. So usually anything that's good for the teeth are low constant forces, okay? So during the post-lag phase, you will see the removal of hyalinized tissue after the bone deposition and bone resorption process. And you will see the tooth movement after all this series of tooth biology, of the movement of the tooth biology. And when we're talking about bone resorption, you will find two types of bone resorption. One is the frontal resorption, is what we want. The other one is called the undermining resorption. So under frontal resorption, usually you will get it when you have light constant force. You will see little or no hyalinization, so the lag phase is short and straightforward. You're not going to use a lot of time. The optimal force for the frontal resorption is usually between 20 to 26 grams. So it is a force that is optimal for tooth moving in a socket. And this pressure is close to the capillary pulse pressure. On the other hand, when the force is too heavy and it is continuous, you will get undermining resorption. you're going to see large hyalinization areas. And usually the force level for undermining resorption takes place when the force are above 26 grams. So if with less force, you're going to see less pain in the patient. The patient will be more comfy. If there's more, the force is high, or if there's more force level subjected to a tooth surface, the patient will have more discomfort, and the patient will be more painful during treatment. So as you can see here on the left, you will see a picture of the frontal resorption in which life force is induced on the tooth surface near the center of rotation. You will see the resorption is on the anterior region of the alveolar bone. You're going to induce cellular activity that causes bone resorption and bone deposition. And as a result of this process, you're going to get tooth moving in the socket in a healthy way. However, if it is a high force, you're going to get rear, bone resorption and cell death on the rear end of the alveolar bone. And as a result of the undermining resorption, you're going to get some gingival recession or some other detritus effects on the gum. So high forces are not good for a tooth during orthodontic movement. So usually during the 3 phases of tooth movement with different force level, during the initial phase with live force, you're going to get the alveolar bone bending, and the piezoelectric signals will be generated, and you will see tooth move within the PDL. You're going to induce less pain if the force is light, right? But if the force is heavy, you're going to get more pain. After a few seconds, you're going to enter, the tooth is going to enter into the lag phase. Okay, during the lag phase, in the light force category, the blood flow is altered, metabolic changes with cellular differentiation, and this will last for about a few minutes to a few hours. Okay, however, when a heavy force is induced and the tooth enters the lag phase, you are going to have a cut off of the blood flow. You're going to induce cell death on the compressed area. Okay. And after 2 days with live force, you're going to see frontal resorption, and this is less damage for the tooth. And we're able, to repeat the process again, and the teeth will continue moving. However, with the heavy force, for the post-lag phase, it will last about 5 to 14 days. Okay, you're going to get undermining resorption. This is more net damage for the tooth. And usually with heavy forces, the total treatment time will be longer. So this is the difference between the light and the heavy force that is induced on the tooth surface during orthodontic treatment. Okay, so after a review of the biology of tooth movement with the 3 different theories, you have a clear idea of how a good force level is very important for our patient. In the following case selections, I will share 3 cases with all of you here today, and I will share on why I chose the device as an add-on to the treatment to help with my cases during the aligner wear. So we'll take a look at the, this one. We'll take a look at the first case, okay? For the first case, it is a 17-year-old growing kid. It is a male, okay? He has a severe class 2 deep bite with lower facial height and a very large overjet. The mechanics that I planned for him was segmental distalization to correct the class 2 malocclusion into a class 1 malocclusion. And the projected aligner wear, the total treatment time was 35 months for him. However, with the implementing and combining the vibration device, we're able to finish the case within 22 months. So this is the boy before and after. As you can see here, he's rather brachycephalic, okay, and with anterior deep bite. The orbicularis muscle are rather, it's not, there's some myofunctional muscle dysfunction. And this is him before and after. We'll take a look at his intraoral status. He's about 17-year-old with class 2 large overjet. There are 2 sets of aligners for him. On the first set, there were 70 aligners, and on the second set, there was 35 aligners. With the system, we asked the patient to wear the aligner for 7-day protocol for the first set of aligners and 5-day protocol on the second set of aligners. Usually in the start, when I start to use the device, I usually combine the device with patients with any aligners more than with aligners more than 50. Okay, so because I want to save some time and I want to induce a better bone remodeling rate, so I just want to see how it works with the patient. So usually any patient undergoing aligners for more than 50 aligners, I will usually encourage the patient to use the system. So, so this is the clean check plan. On the lower arch, we plan simultaneous expansion to decrowd some of the crowding on the lower arch. On the upper arch, we can go back a little bit. Okay, on the right, it is K9, nearly K9 class 1, okay, and class 2 on the left. That's why the treatment goal or the object of the clean check was to distalize the upper left, okay, and together with class 2 elastics, we are going to correct his class 2 malocclusion. So this is the proposed clean check plan, okay? As you can see here on the first set of aligners, there were 70 aligners. He has an overjet of 7.6 to start off with, and an overbite of about 2. We want to correct him to finish at overjet of 2 and overbite of about 0.6, okay? So on the upper arch, it is simultaneous retraction on the left, on the right. However, on the left, we plan segmental distalization for him. And as all of you know, with any doctors with the aligner experiences, you know that with segmental distalization, it takes time. And the tracking is also very critical. Sometimes you get a lot of tracking and a lot of open bites after a set of or a series of aligners with distalization protocols. Okay. So this is overjet to start with, and this is the final that we want to get, okay? So for me, usually I have easy mechanics for aligner system. So it's segmental distalization and class 2 elastics for this case. So this is the clean check. As you can see here, teeth move back one by one on the upper left quadrant, okay? This is nothing new. When you're using the aligner system, you should learn the power of segmental distalization. It will help with a lot of your cases as well. And for this case, because it has overjet, severe overjet of 8 millimeter, so I did some over engineering at the end. I tried to finish at a negative overjet, okay? And this is him during the intercourse of the treatment. As you can see, after 5 months of treatment, the class 2 canine merely changes to a class 1 canine, okay? And there's a lot of open bites on the posterior region. There's some interferences and premature contacts on the anterior region, as the laterals, the instanding laterals 1, 2, and 2, 2 seem to be a little bit locked in still, okay? And after 1 year and 2 months, we almost finished all the aligners, and we stopped there to get additional aligners. Because as you can see, something is happening, right? Of tracking posterior open bite. I need to solve that. So I just stop and I do another scan, and we send in for another additional aligners. This is the occlusal upper and lower view, okay? Decrowding is great. The arch form is good with the aligner system, okay? As all of you know, the first number one power the number one most powerful mechanics of aligner is expansion, right? So nothing new with the upper and the lower arch. You're going to get good arch form if you have a good clincher design and you have a compliant patient, okay? I only ask the patient to pull class 2 elastics on the left quadrant, okay? And you can see all the spaces that open up during 5 months, okay? The tracking is good, okay? So after a year, we did another scan for the additional aligners. And for the additional aligners, it comes up to be about around 35 aligners in total, okay? And the goal of this treatment is to do simultaneous expansion on the upper arch. As you can see that after the segmental distalization, the posterior arch form had been skewed, or it's been narrowed, and the buccal overjet on the posterior region is not enough to fix the posterior open bite. So we need to expand the upper arch a little bit more, okay? And we are going to do bisettling, okay? And so that the patient will have good interdigitation at the end of the treatment. As you can see, we have some IPR to get some space, to correct some crowding, and to do some intrusion. Usually a tip here, I love to do my IPR at the same stage, okay, and at the same appointment to decrease any inefficiency, or to give patient a better sense of feeling that we're not cutting their teeth every time they comes in. Okay, so that's a good tip. So this is the proposed before and after clean check plan. Okay, so let's see the clean check. Okay, so on this clean check, we are going to fix the posterior bite and do some upper posterior expansion. There's a jump at the end that I induce because I will be using up and down elastics for the patient. So this is the patient, okay, a few months after the additional aligners, okay, and at the end of the treatment, we're able to finish him with good interdigitation on the posterior and canine class 1 relationship. The midline is a little bit off. There's some Bolton discrepancy on the lower anterior region, but with this type of cases with non-extraction, the proposed treatment time, I think, was 2 years, more than 2 years, but we managed to finish the case within 2 years. So that is quite interesting for me, okay? And this is the arch form, before the additional aligners and after the additional aligner. The second set of aligners, it took about 4 months for the patient to finish with the detailing and the posterior bisettling on the right buccal and left buccal. Okay, this is the panoramic before and after. As you can see, all the wisdom teeth are still intact. Okay, there's some widening of the PDL at the end of the treatment. The root axes are good and parallel to each other. Okay, however, we asked him to have the wisdom teeth extracted after the treatment. And this is the cephalometric change before and after the treatment. Look at his chin button. With a 16, 17-year-old patient, the chin still grows, okay? There's still some potential for the patient. if you're able to advance the mandible a little bit with the class 2 elastic. As for this patient, I didn't use MA as this was one of the earlier cases in 2016 when the MA is not launched. So we used the class 2 elastic to correct his class 2 bite. Okay, so whenever you come out with a large overjet and you're aiming for non-extraction and you're using segmental distalization and the aligner number is more than 50 aligners, I think it's a good indication to give it a try, because you're going to induce less lag days for the tooth movement, and you're going to save a lot of time, and you're going to induce less pain and allow more tracking for the tooth moving in the patient. So let's take a look at the second case. Actually, the second case is the light for my treatment with the device. It shows light for me. During the initial late days, I am also skeptical, as most of you are, with the system. We are not very confident with the system, with the treatment in our patient, and we don't see a lot of good results in our patients. And there's not a lot of information on the market in which we are able to get and study and review. So usually we try on our patients and we see how it goes. For the first few devices, I didn't feel anything. But with this case, okay, it really shows something, and I started to pay attention, with this technology, and I started to look at some information on tooth moving after orthodontic treatment. So for the second case, we are looking at a 48-year-old female. Okay, it's also a class 2 deep bite with also a low facial height and large overjet, similar to the first growing kid. However, because she was a little bit middle age, I tried to do non-extraction with tats. I want to do anterior retraction with tats. So I have all these design mechanics for her, and then we'll see what happens. Okay. After the second set of aligner, we planned segmental distalization for her. The projected treatment time for her was 40 months. However, we used about 28 months to finish her, as there were 3 sets of aligners in total, as we can see in the following. This is her. She's a class 2-2 case, okay, with low facial height, okay, a little bit bracky, and the teeth not looking good, and the lateral sticking out. Okay, this is her before and after the treatment. Okay, as you can see here, the canine is class 2 on the right and on the left. The molar is also class 2 on the right and on the left. It's a full class 2 molar relationship. She had 3-7 missing on the lower left, okay, and some crowding, and the arch form is rather squarish on the upper arch, okay. The bite is deep, the midline is off, okay. So I planned, because she doesn't want any extraction, and she has some perio problems on the upper posterior molar area, so she wants to try non-extraction, okay. And so I asked her that actually this is an extraction case, but I told her that, oh, maybe we can try tats. Okay, we can use tats, and together with the power arm, we're able, to retract the upper anterior. So for the first set of aligners, we didn't implement, or we didn't combine the device within the treatment. Okay, so she just when the aligners comes back, it was 50 aligners, and we put her on the first set of aligners. Okay, there was no accelerating device used during this first set of aligners. Okay, and this is her clean check. Okay, as you can see, I put the power arm at aligner 9 and the tats at aligner 9, and we started using power chain, okay, to fix her class 2 relationship. Okay, so this is the progress of her treatment. As you can see, after 5 months, it looks like the bite opens a little bit. However, there's not much retraction. There's a little bit of leveling and alignment on the anterior region. Okay, as you can see, even though you cannot see the tats between 6 and 7, but you can see that I had power arm hanging up high. The power arm, the wire that I use is a 0.36 round wire. Okay, I bend a question mark. Okay, and then I bond it onto the canine, and then I run the power chain to the tats. Okay, and after about 10 months or 11 months, you know, as you can see, the open bite appears. There's a little bit of space, but you know that the retraction is not really working well. Okay, this is the upper and the lower arch. The arch form is good. Okay, I did some IPR. As you can see, we are not getting a lot of retraction from the TAD mechanics. Everything looks stuck. Okay, the bone looks stubborn. The teeth is not moving well. Okay, it only levels and aligns, but there's no retraction seen in the mouth. So we have to do something. So at 11 months, I stopped. Okay, I talked to the patient. I have this thing in the clinic. I asked her, "Do you want to give it a try?" I think it's worthwhile. Okay, so I changed the treatment plan. During the first set of additional aligners, I planned differently. I tried segmental distalization as I'm using the device together with the treatment. And as you can see here, the total number of aligners that comes out was 99 aligners. I'm not sure why I approved this plan. I just thought that, oh, maybe we can give it a try with this device, you know, with 99 aligners. I never do something like this now, okay? When you see any clean check that comes back with more than 50 aligners, you have to replan, okay? Because the more aligners you have, the more of tracking you're going to induce. And it is also a magic number that gives you an indication that maybe the treatment plan, you need to change your treatment plan so that it's more optimal for the patient. So as you can see here, the bite is still deep, the overjet is still big. Okay, there's still some jet. The jet is still 7. Okay, nothing changes nothing changes much. So we plan segmental distalization for her together with the device she would use. There was 99 aligners in total. Okay, so as you can see here, okay, 7 moves back halfway, then 6 starts moving, and then 4, 5 move together. After at its final position, the anterior incisor will start moving. This is my usual protocol for segmental distalization. I like it this way. I think it's very predictable and very very ideal for the patient. And I did also some overcorrection at the end, okay, to correct the large overjet. Let's take a look, okay. That was like 11 months. And after about another half year, okay, we can see large spaces, okay, from the distalization protocol. As you can see, the space between 5 and 6 at 1 year and 6 months, okay. The anterior, there's no movement yet, okay. And in another 4 to 5 months, you can see that the premolar started to move. And after the premolar moving, can you see that the 1-2 and 1-3, the 1-3 had intruded, okay, as a result of the equal and opposite force. Okay, when you do distalization, you're also going to get proclination on the upper anterior. And then there's some extrusion of the lateral incisor. There's something wrong with the gum. Okay, so I cut the aligner a little bit low to help solve the situation, and it was good. Okay, as you can see, after 4 to 5 months, at 2 years time, we're able to fix her period problem in that 1-2 area. Okay, so at 2 years, we finished the 99 aligners. Okay, I used the 7-day protocol for her. Okay, the midline is on. There's no elastics used, only segmental distalization and the vibrating device. Okay, the lower 3-6 is a little bit mesially inclined. Okay, can you see the spaces that open up together with the device? I think this is what we are looking for, and it makes our days happy. You know, if you're going to have 99 aligners and you still get stuck, well, that's like torture for us, and it will have a lot of pressure in our daily clean workflow. Okay, so this is her. Okay, during the second set of aligners, this is additional aligner 1. And after the second set of aligners, we try to finish her with the last set of aligners. As you know that we had some posterior open bite, there's still some tipping. We want to do some bisettling. And for the last 23 aligners, we used the 5-day protocol together with the device. We did more intrusion in the upper anterior region to help treat her class 2-2 and to reduce her anterior overjet. Okay, so after the second set of liner, we're able to decrease the overjet from 7.8 to 2.5. Okay, so this is the last set of additional aligners, and you can see here, okay, the before and after. We're able to finish her luckily at 2 years and 4 months. It's not very perfect, but I think it's good for her with non-extraction. And we're able to finish her with class 1 on one side and class 2 on the other side. So as you can see, her bone is very, very strong, very bony. Okay, it's really hard sometimes in this type of patients to get a lot of distalization, or even though you have a very predictable way of doing anterior retraction. And this is the arch form on the upper arch and on the lower arch. And this is her change in her lateral profile. As you can see, there's some advancement of the lower mandible. The upper and lip posture are more balanced at the end of the treatment. Okay, and she liked the position of her chin now. Okay, and so this case is the learning curve, and it's also the turning point for me as well. Okay, so the last case that I'm going to share is a case with crowding and rotations, especially also in middle-aged patients. Usually I like to try it on middle-aged patients, as you know that a lot of patients in their early 40s or late 40s usually have very stubborn bone. And with all this stubborn bone, it's really hard to move the teeth, you know, in their mouth. So we're always looking for ways and looking for methods on how to make the teeth move better, not even faster. Usually with AcceleDent, I don't reduce the aligner wear too much. I use the system as you know, as a device for tracking, as a device for inducing better blood flow, so that the lag base will be short, so that we're able to see the specific tooth movement that we are planning. So for this last case, it's a male, okay, with class 1, crowding and some rotations. Also very stubborn bone. The mechanics we planned for him was simultaneous expansion on the upper arch and lower arch to decrowd and alleviate the crowding. the projected treatment time was 15 months, but we actually finished him with one set of aligners with 10 months. Okay, so this is him before and after. It's not a very serious case. It's not a very difficult case or challenging case. The thing that is challenging for this case, one is the age. The other is the instanding lateral that's crooked, behind the central incisors. So this is his small occlusion. As you can see, it's class 1 on the right and a little bit class 2 on the left, and the midline is up. You can see that there's rotation on upper 2-1 and 2-2, okay? And it's usually when you look at male patients and you check the gingival line of the upper incisors, and you see the protuberances on the overjet photo. As you can see there, you see all those bony structures, and it's hard, it's rigid, and it's stubborn. And you know that even though the crowding is not very severe in this age group, sometimes it's very difficult to decrowd and alleviate the crowding. And you see all those bone bulging out from 1-2 to 2-1, as you can see on the photo in the center on the top. Okay, you can see the bone is bulging out. So he also wants the treatment as fast as possible. So I introduced the system and the device to him. He takes it very seriously. He uses it every day. Okay, there was 44 aligners for him. Okay, the treatment plan was simultaneous expansion, simultaneous staging for him. Okay, there was only 44 aligners. We used the 7-day protocol. Okay, and usually with aligner, it's a push force. So anything that's crooked inside or that's stuck inside, I like to put the attachment on the lingual side rather on the buccal side. One, the path of insertion will be easier to remove and to put on. And the other way, it's a good way to push the tooth out of the archbone. So this is him, okay, before and after on the ClinCheck plan. And let's take a look at his intraoral view. Okay, as you can see here, it's 8 months. After 8 months, we had some decrowding. You can see that the gum over 4-1 is still looking healthy. And at the end of the treatment, there's no gingival recession. It's very interesting that with this type of malocclusion and in some females, when we integrate the device, we're going to have less gingival recession, but I don't have enough clinical evidence. So I'm still reviewing my cases and looking over, all those photos and studying on how it has helped them and over the treatment time. But as you can see here, the tooth is corrected nicely. There's some bruxism, so we're not able to extrude it to the same level as 1-2. Maybe I'm going to do some gingival surgery or do some veneer for him on the 2-2 area. Okay, but the position, the final position looks good, as you can see here. Okay, after 8 months, the crowding is solved about 80%, and at 10 months we're able to fix the upper and lower anterior crowding for him with healthy gum and no recession, and the root axis is good. Okay, and the teeth looks very stubborn, so I asked him to wear the aligners as long as possible. Okay, so this is him. The bite becomes a little bit shallow. Okay, the lower lip, it's more balanced after the treatment. And this is him before and after the treatment, the changes in the facial profile. There's not a big change, but with crowding and of the age group, if we're able to finish him in 10 months, I think it's good for the patient. It's also good for us, and it's also good for the clinic as well. So after these cases that I've shared, I just want to share some viewpoints on the benefits and the value of implementing and embracing this new advanced technology with the orthodontic treatment that we usually have or what we usually do for our patient. So some of the benefits are by reviewing the different types of tooth movement, the different theories, we know that with with light continuous force, we're going to get less lag phase. By less lag phase, it means the treatment time will be a little bit shorter. We are not going to take up a lot of time during the treatment. There will be less damage to the surrounding tissues, neither whether it's the bone or the soft tissue. The patient will feel less pain, and there will be better tracking. There will be a better tooth movement during the treatment. So these are some of the benefits that you should think about when you're implementing the device, and not just shortening the days of aligner wear. I think these are much better to think, to plan, or to evaluate rather than just lessening the aligner wear, because this will help the patient in the long term. So how about the fixed structure? Truthfully speaking, during the initial phase, okay, when I am looking for the device to be combined into the orthodontic treatment for my patients, I don't have any suggestion or any advices from anyone. So when I bring it into my clinic, I just had add on. If you want it, we will, there's another separate price to charge. It didn't really work well, as you know that this is not a very cheap, device to get. So it is not very successful. It only works in patients just like the second lady, in which the first set of aligner is not working well. And then we introduce the device to her as an add-on, as a supplementary. To me, it just, sounds like a vitamin supplement for her to boost the tooth movement in her mouth. So she takes it, happily. And when she sees that the tooth is moving, she knows that it's useful, and then she will keep using it. It didn't really work well. So I have the simplified package and the complete package. So with the simplified package with the aligner system, usually I don't, there's no combination of the device together. It's simple, okay? So you only use the aligner system. And with the complete package, especially in complex cases or with patients with aligners, more than 50 aligners, usually I will ask them to take the complete package. After I make some adjustments with the structure on how to incorporate into the treatment, it works really well. And patients love it more and more, and we are seeing more better clinical results after a few years. I started using the system in 2015, and it's only like for 5 years. I have a few cases in hand, and I think it's really interesting as it is showing more light for me. As I have more experiences and I gain more knowledge on the system. So these are some suggestions for all of you tonight. Okay, so before we end, I know time is short. I really want to share more. Really want to talk more, but it's really a short webinar. And this is from me, okay, a take-home message. Not all bones are created equal, and it is important to identify those variations and treat them differently, accelerate their bone remodeling rate with less damage. This is very critical in developing and planning an efficient and ideal orthodontic treatment. So if you are interested and curious about the system, I think some of the indications that I've shown here today are, if you have aligners, more than 50 aligners, and class 2 device and you're asking for non-extraction, as I also use with extraction as well, it also really works well, and especially together with the G6 protocols, and the tracking is really nice, but it's not a finished case, so I'm not showing it here today, but if I have the chance, I think we will see more case reports, okay, after I have more chances of seeing everyone here on the webinar, okay. So we'll stop for a few minutes for any questions. If let's see if there's any questions from the audience.
Chiu, excuse me. Thank you very much for sharing your knowledge and experience with AcceleDent. I hope everyone was able to enjoy that and take away some information, especially with a large group of people who aren't familiar with acceleration protocols. We do have some questions, and I forgot to mention in the beginning for you all to, at any time, ask any questions during Dr. Chiu's lecture or presentation. So if you do have any questions, there is in your bar a section where you can type in your questions if you haven't already done so. So we do have a few questions that I'd like to go over with you. And we might run a little bit past our original time. If you can stay on, please do. I think the question part is always the most useful and informative. So the first question, with COVID-19, I want to reduce the number of visits and exposure for my patients. Do you think that I can deliver more aligners along with an AcceleDent device between visits and achieve the tracking?
Yes, this is a good question. Yeah. During this COVID situation, before I integrate the device, and usually I had a 2-month recall for all of my aligner patients. But after I integrate the device, any patients that uses the device, we will usually see them in 3 to 4 month recall. So it's good if you are facing, the crisis that we are facing now, and you have a good device, a good technology at hand, and you also know that the patient is compliant. So usually my protocol is, if the patient is using the system or the device, we do not give it to them at the first appointment. We will see how they wear the aligners for the first 2 months. And if they are very compliant and they are very cooperating, we start to distribute and deliver the appliance. We talk about the pros and cons to them at aligner 9. So usually I deliver the aligner at aligner 9, and we will give the patient 3 to 4 month amount of aligners, so that we'll schedule the patients back after 3 to 4 months. And usually the tracking is really well, okay, if they use it, and if they don't use it and they're not compliant, no matter how advanced the technology is, it's useless. So besides having a good device at hand, you also need to educate the patient on the compliance of wearing the aligner as well.
Thank you. I have another question. What is the most important benefit you have discovered using AcceleDent?
I think with this, usually the patient's feedback, usually the first one is less pain. They feel less pain. When they use the first 8 aligners, they feel more pain. There's more this tension, and it's the teeth are more tender. However, when they start using the AcceleDent, okay, they feel less pain, and they think the aligner becomes loose faster than the first few aligners, and they like it. That is the first feedback from the patient. On my side, with the combination of the device and implementing the device in some of my patients with the system, I find that the tracking is much better. Okay, we can see that the wrap of the plastic around the tooth surface is usually better than patients without the device, especially in the middle-aged patient group. And in large overjet in which we want to tackle it with non-extraction, which initially was the extraction case. So I think those are 2 of the biggest benefits and advantages that I'm seeing in my patient together with the device.
Okay, thank you. Another question, for patients wearing elastics, do you still require weekly change, or do you have weekly change and not 2-week change? And thank you, Dr. Maggie, for an excellent presentation.
This is Dr. Eileen from Malaysia. Nice to see you. Yeah. For patients wearing elastics, do I do weekly change and not 2 weeks change wearing elastics? I think Dr. Eileen wants to know how my elastic protocol is. Usually for my elastic, the patient changes every day, and they change 3 times a day, because usually I don't trust my patient a lot. So when you ask the patient to change the elastics 3 times a day, they will only change 2 times a day. And with elastics, I don't do weekly change or 2-week change. Usually, if I'm correcting a class 2, I will use the elastics until canine class 1 is established, and then the patient can stop using the elastics. If it's a class 3, I will start using the class 3 elastics at aligner 9 still, and then the same, okay? And when the patient reaches class 1 relationship, we will ask the patient stop using the elastics.
And then Dr. Eileen had a follow-up question.
Oh, the aligner change. Oh, okay. So yeah, I never use the 2-week aligner change now. Usually it's 7-day aligner change. The 7-day protocol. And usually with additional aligners, I will, because there's not much to correct, and most of the correction have been done during the first set of aligners, I will try to lessen the number of wearing for the aligners. Usually I will go for 5 days. I never do anything less than 5 days. As you can see during the first part of the presentation, for the lag base, it usually lasts about 2 to 3 days in a low constant force. So anything less than 3 days is rather tricky, and it's not very good for the tooth. So if you're combining with the system, I urge that everyone uses at least 5 to 7 days protocol for their patients.
And that was perfect that you touched on that, because we had another question where a doctor asked, do you treat every patient in 7 days protocol? So it sounds like you typically use 5 to 7 depending on the case. And I have and another question. Hi, Dr. Chiu. Have you heard of carrier motion? And do you feel whether carrier motion can replace acceleration protocol? Would you recommend patients to use carrier motion or AcceleDent or both together, or is AcceleDent sufficient or efficient enough?
This is also a very good question, as a lot of doctors get confused on carrier motion and the acceleration protocols. Actually, there are two different things. As for carrier motion, it's a distalizer. It's a class 2 distalizer. So it's something like a pendulum device that moves the molars, posteriorly. However, with acceleration or with this AcceleDent device, it's not a distalizer. It helps with the tooth movement. It helps with the ease of tooth moving in the socket. So it's just like it's like for AcceleDent, I put it another way. It's just like the policeman, and they are there to guard the tooth traffic and reduce the obstacles for any complex tooth movement with with brackets or with aligners. So actually, there are two different devices, and they have different treatment goals. As for carrier motion, you're only able to get distalizing effect, but you're not able to induce better bone modulation to ask for better bone remodeling rate in the mouth. So I think they're different. One works at a cellular level, and the other one is more like physical level. It's like it's only moving the molars behind. But you can combine the both. If you have a class 2 to start with and you want to correct it to class 1 quickly, you can combine the carrier motion together with the AcceleDent as well. So you bond the carrier motion, and then you ask the patient to use the device for 20 minutes every day. I think it will help with the distalization protocol as well.
Okay, thank you. Next question, Dr. Chiu, if there is resorption undermined so that the tooth cannot move forward, could this instrument overcome that? Thank you. I think you can see the question too.
If there is resorption or if there is undermining resorption so that the tooth cannot move forward, yes. Because with undermining resorption, you have a lot of hyalinization. With hyalinization, that means the blood flow is cut off. There's no blood flow. The moves very slowly, or sometimes it's stuck there. Could this instrument overcome? Yes. Usually, if there's undermining resorption, you need to reduce the force, or you need to stimulate all those prostaglandins to release all those mediators to boost, tooth bone remodeling rate to induce better tooth movement. So if there's a lot of tooth resorption or not tooth, a lot of undermining resorption, I think it's a good chance or good indication that maybe you want to implement, something to something like you increase the blood supply and the circulation in the PDL to help boost with the tooth movement.
That's actually a really good segue into the next question. Hi, Dr. Chiu, do you have any special protocol for patients post-perio treatment to use AcceleDent? For example, patient has perio problems with second-degree mobility, treated nicely and no more mobility, but bone was remaining only half of the movement.
Yeah, hi UK from Indonesia. Okay, usually if this is the case, usually there is undermining resorption. They don't have the frontal resorption. During the the resorption and the bone deposition progress during a tooth movement. So after the bone is lost, if you want to combine it with the device, I think it's not retrievable. You cannot go back. It's not retrievable. However, if you notice that there's some perio problem at the start or initially, you can ask the patient to use the device together with a special design of the aligner. For example, in my perio patient or in that lady, when I found that the 1-2 is extruded, I still asked her to use the AcceleDent, as you can see, but I did some trick. I cut the aligner a little bit short, halfway, that it only covers the tooth halfway. And together with this light force, working on the tooth, it will help with the intrusion and the inflammation of the gum. So if it's already happened, I think it's not retrievable. But if you notice that it's a perio patient or perio treatment, you see some indications there, you can start early. However, if it's already happened, it's I think it will not work well in patients with already those bone destruction, as the device is not a device for growing bone. Okay, because anything, if after the perio problem and you're not moving the tooth, there's no more tooth resorption and tooth deposition process. You need to induce a force on the tooth in order to induce the process again. So after treatment, the bone is lost, it's lost. Okay, you need to find a surgery doctor. Okay, and not seeing the light in the device. You can use the device earlier in the treatment to prevent this from happening. So I think this is my answer for Dr. UK.
I would agree. Would be a good to use it if you see a situation like that. Use it early on and to help prevention or further resorption. The next question for class 2, divid 2, with weekly change. Have you experienced any lag delay of torque expression? You increase from 7 to 10 days aligner change. Thanks for sharing your knowledge with us.
Yes, usually for class 2 too, it's usually difficult. Okay, it's a very complex and challenging case. I use the 7-day protocol. Okay, and with the torque expression, usually with the aligner system, we need to see if the power rich design is effective. Usually the torque expression is delay or there's a lag. Is usually the power reach design is not working well. So we need to check whether the indentation touches the tooth surface. If it touches the tooth surface, it's gonna express well when the patient use the chewies more. So with the class 2 and you have problems with the torque expression on the upper anterior region, I asked to use the chewy more, or you can incorporate the system so that it looks it works like an automatic, chewy, and the patient, it will help with the the sitting of the aligner onto the bottommost of the tooth surface, and it will help with the expression of the torque. However, when the torque expression is not good or is not effective, I will not increase from 7 days to 10 days. I will check the power reach design first. Usually the problem is after the manufacturing of the aligner with the power reach, and when we deliver it into the patient's mouth, it's there, but it's not touching the gum area or the gingival area, so it's not working, and the design is not good to change or induce a lingual root torque. So this is my answer for Dr. Penny.
Okay, another question. And Dr. Chiu, just let me know. We have a few more questions. If you're good with time, I'll
Yeah,
continue. Okay, thank
yeah,
you.
I'm sure. Yeah, we can finish the questions.
Okay. How has AcceleDent been a differentiator for you in your clinic, and when did you first notice a positive ROI?
Can you repeat the question again? How is it a changer? And I didn't get the last part.
Okay, yep. How is it a game changer for your clinic? And when did you first notice a positive return on investment or a
Oh, okay.
return in your clinic using AcceleDent?
I think it's a game changer after I've used it for about a year, and I start to see some good results in my patients. In the lady, during the first round, I didn't implement the device, and during the second round, when I implement the device, I'm seeing a lot of spaces, coming out from her mouth, and she's excited, and I'm excited, and she knows that she has very stubborn bone. That is the time, I start to rethink again, and I start to have a little bit confidence in the system. And then I start to use it more and more. As I start to use it more, I see that I'm using less additional aligners, usually with AcceleDent in cases that are really challenging. Usually I can finish it within 2 sets of aligners, or the maximum 3 sets of aligners. And I think it takes some time, and it doesn't really come this fast, just like me, but it will take some time, and after some we need to have some data, at hand. We take records and we study from our cases, and that is the time that I start to see some light, and I start to use more and more. And because with the version now, it's more friendly, and it's more patient, it's easier for them to use. It's patient ease. So we are also learning with the system, and we're also learning with our patients as well. So if you have a chance, I think just start use it for a few cases, and then see for yourself, and when you're confident, maybe you can have more, and you will see something that is the variations between patient with the device and without the device.
And I agree with that comment. I've heard that same thing from other doctors when they first start using it. It's like with any new device or appliance that you use, even when you start using aligners or brackets, it takes time to get comfortable with it, to get more experience, and to get confidence with it, and then to be more efficient with it. So that's a great comment. Another question. Can you explain again about the TAD on 13 and 23? Do you, my glasses, do you bond the hook before scanning or bonding by cutting the aligner?
Oh, okay. The TAD is between upper 6 and upper 7 at the zygomatic buttress, okay? The TAD is not on the canine. Let me drag it. Okay, let me see. The second one, okay. Can you see it here? Oh, let me see. The TED. Okay. The TED is on upper 6 and upper 7. It's hidden behind. Because I use a wide retractor, you're not able to see the TED, but you can see it on the occlusal view, as you can see it here. Can you see it here? Oh, here. You can see here. Can you see here? Between upper 6 and upper 7 on the right, on the left. Okay. This is called a power arm. With the power arm, you can design and plan on the clean check before you bond it. So you don't have to bond it, and you don't have to do the bonding and then scanning. You can design after after you scan everything, or you take the impression, and then with the power arm, it looks like an attachment, but the opening over the gingival area, it's wider, so there is the space for you to stick this power arm into position, and you can pull the elastics from the power arm to the tabs. I want it to be, perpendicular to the root surface. So I make my power arm a little bit, longer, so it's parallel. Okay. As you can see, here's the power chain. Okay. And you don't have to cut the aligner. It's already manufactured with a wider opening on the top.
Okay, thank you. Another question was, how often should patients use the AcceleDent per day? And I can answer that one. It's 20 minutes a day. I typically like to recommend that you wear it in the evening because you already have cellular stimulation regeneration while you sleep. So it's a good tool to enhance that activity before your nighttime routine. And it's also kind of relaxing from what I've heard from patients. It's a soothing effect, a gentle massage that kind of helps put you in that sleep mode. And Dr. Chiu, there's a question here, but I don't know if you'll be able to answer it if you have experience with Propel. Question is, how's the efficacy of AcceleDent compared to Propel? 20 minutes seems long compared to Propel's 5 minutes.
Yeah, I've heard about Propel. It's a more higher frequency and higher force, because I know AcceleDent before Propel. As you know, during our early days, the king of Invisalign, that is Dr. Kenji. I learned this system and device from him, and then I started using it. And then from my own experiences, I have my own learnings. But with Propel, I think the problem with it is that it's a higher frequency. As we mentioned in the earlier slides, the optimal orthodontic force to induce on the tooth is about 20 to 26 grams. Okay, with Propel, I believe it's more than 26 grams. That's why it only works for 5 minutes. But I don't have a lot of experiences with Propel, and because for me, it's kind of, I think, rather intensive and rather more advanced for the patients. But if I have a chance, maybe we can try it, and then we'll see how it goes. But according to all those reviews and studies, I think AcceleDent sounded safer. It's like it's more optimal. It's a better optimal force that will induce less damage on the tooth structures, and it will induce less black face. Because with Propel, I don't have the information at hand, but I believe that the force level and the vibration is a lot higher than the AcceleDent device. But it's always good to give it a try because it's only 5 minutes. But anything that's too strong, as you can see, heavy forces will easily induce larger hyalinization. With hyalinization, you're going to get longer treatment time. So in the long term, I think it's not good for the health of the tooth structures.
Okay, thank you. And this is the last question that I see. If anything else pops up, I'll let you know. Have you seen an increase in referrals or positive reviews from your AcceleDent patients?
Yes. Usually, patient will not give a positive, feedback during the first few months that they use. But after a few months that they start using the devices, usually just as what I've mentioned, they will tell me that, oh, they don't feel any pain and the aligner feel loose, after 2 to 3 days. Can they, swap to the next aligner faster? Okay, but I usually tell them that, always keep at least 5 to 7 days wear for each aligner, and then always check the tracking and always check the rep. And I try to incorporate more cases with the system nowadays. It's not all in my patients now for everyone. It's not a must, but usually the indications that I'm looking for are those, complex cases and cases with a lot of aligner numbers. And I think that will help us in the long term, and it will also benefit our patients as well.
Okay. Well, thank you. I don't see any more questions. Thank you for staying on later, and thank you to the doctors who've also stayed on later to hear the Q&A section. I appreciate everyone's time, especially Dr. Chiu's. I know it's quite late in Asia right now. As it gets light outside my window, it gets darker and darker there. So Dr. Chiu, thank you again for sharing your time and your experience with AcceleDent. And if there are no more questions or any comments from you, Dr. Chiu, I'd like to end the presentation and have
thank you
everybody.
everyone for joining today. Hope you have something to bring back and that works for your clinic. And I'll hand this over to Tina. And thanks, Tina and the team, for setting up the webinar, as this is a new platform for me as well, but it looks very interesting. We are always learning from each other. And thanks, everyone, and have a good night.
Oh, Dr. Chiu, sorry, everybody. So China has some participants, but because of the software, like you said, it's a new platform, they're using a different software to broadcast your presentation live. So I just received one question. What is the favorite protocol for acceleration device, for using an acceleration device?
My favorite protocol? Okay.
Mm-hmm.
Okay. Usually with the AcceleDent or the accelerating device, my protocol is still the same with the 7-day I use the 7-day protocol for the first set of aligners. On the second set of aligners, I will stick with the 5-day protocol, and the least amount of aligner wear is 5-day for most AcceleDent users. I never go for the 3-day, and I think 5-day is the least aligner wear that I am using for my patient.
Okay, thank you. And with that, I wish everybody a wonderful evening, and please stay safe and healthy while you're traveling and out there and seeing your patients. Take care, and everybody have a nice evening.
Bye.
Bye.